Some patients, after they've had either aortic or mitral valve replacements, develop late post-operative complications, and that complication, one of the complications, is of a leak outside the valve ring where it's been stitched in by the surgeon. There are various reasons for that. Sometimes it's due to an infection, but quite often it's just due to a retraction of the tissues or a deterioration of the link between where the valve has been stitched in and the tissues of the patient. And if that happens, then there is a leak between those two chambers which doesn't go through the valve, it goes outside the valve ring, therefore it's called paravalva. When this happens, often the problem is to do with the difficulty with the initial operation in getting stitches into the patient's tissues. Sometimes these tissues are very calcified. And so repeat surgery is often quite a difficult thing to do because already you're dealing with a patient substrate, if you like, which has a tendency to cause these problems. And repeat surgery anyway carries much higher risk than first-time surgery because it's always harder to repeat an operation because the tissue planes and so on are harder to dissect into, and of course patients are older and therefore the risks are higher for a number of different reasons. So where it's possible to close these leaks, we try and do it percutaneously. Now many of these leaks don't need closing, but in about 1 to 5% of cases there are paravalvular leaks which cause significant problems for the patients, and the main symptom most patients develop is of breathlessness. Occasionally this is compounded by hemolysis. As the blood is squirted with high velocity through these small holes, the red cells break up and the result is the patients become anemic and jaundiced. So a combination of dyspnea and hemolysis is usually the indication to try and close these holes. So what I'm going to do is show you a schematic diagram which shows you how we approach mitral valve leaks, and then I will show you how we approach aortic valve leaks. This is the mitral valve leak schematic, and you can see here the left ventricular cavity, this is the left atrium behind, and between the two is the image of the prosthetic surgically stitched in mitral valve. And just outside that valve you can see the leak, which is indicated by the blue dot. So in order to close these leaks, the usual way we would approach this is to go from the right femoral vein. We insert a catheter up the inferior vena cava into the right atrium, and then we cross into the left atrium using a transeptal puncture. And once we have a transeptal sheath across into the left atrium, we then try and deploy equipment and eventually a device into this hole. We start with a variety of different shaped catheters. In this case, a left Judkins 4 catheter has been used and is positioned to allow a slippery wire called a Terumo wire to seek and cross this hole. This can be quite difficult and takes a lot of different manipulation, is dependent on where you've crossed the septum, and sometimes you need to use steerable sheaths and sometimes you need to use different shaped catheters, but eventually you cross the hole. Once you've crossed the hole, it's then possible to advance that catheter across the hole, and then you can take this slippery wire out and exchange it for a stiff supportive wire, and usually we'll use an Amplatzer extra stiff wire. With that wire in place, it's then possible to remove this catheter, which has been shaped specifically to get into that hole, and replace it with a delivery sheath. The delivery sheath has a larger lumen and allows the device to be passed into position. And so here you see that the stiff wire is now taken out and the device is now advanced up and round and is beginning to emerge from the end of the delivery sheath. These Amplatzer devices are designed so that they can be constrained within the sheath, but as they exit the sheath, they form their original shape, and you can see here it's formed the first of the distal discs. This is then pulled back into position, and then the proximal disc is deployed, and then the delivery sheath is detached, leaving a device in the hole, so plugging the hole. I'm now going to talk about how we usually close aortic paravalvular leaks. So in this schematic, here's the left ventricular cavity, this is the aortic root and the aorta. This is the surgical aortic valve which has been stitched into place, and this blue dot represents a paravalvular leak. These are often more straightforward to cross than the mitral leaks. It requires usually a retrograde approach, and so we usually go from either the radial or femoral artery, send a catheter retrogradely into the aortic root, and here we're using, for example, a right Judkins diagnostic catheter, which is often a shape that seems quite well suited to finding these holes. Through that we then feed a slippery steerable wire, and in this case a Terumo wire, which has successfully found that hole. Once the wire is through, we can then advance the catheter so that it's sitting in the left ventricular cavity. And we now have a route through the hole into the left ventricular cavity. We can take this slippery wire out and exchange it for a stiffer supportive wire, which then allows us to remove that sheath and deploy a delivery sheath. This has got a large illuminant and allows the device to be deployed. So as you've seen in the previous situation, we then move the device into the sheath. As it exits the end of the sheath, it adopts its shape, is drawn back into position. The proximal disc is then deployed, and finally the cable is unstitched and the device detached and left in position. Now, both in the aortic and mitral valve positions, there's often a leak through these mesh devices because these are just 6 layers of nitinol mesh. But very quickly, over the course of hours and days, the mesh seals, and usually the paravalvular leak is greatly reduced or eliminated. And we've had there are quite good series showing very good results with these devices, particularly in the aortic position, where I think the technique is quite simple and the results are very good. In the mitral position, they're slightly more variable. The problems that can occur include the device, if the device doesn't fit the hole properly, you may have a leak around the device. The device may become loose and detached and can embolize, which is unusual. And finally, if there is still persistent leak, sometimes you can see an increase in hemolysis after the device is deployed. And in our experience, if that happens, it often resolves spontaneously over the course of the next few weeks.